Okay. Well, thank you, Owen. I want to thank BCT for the invitation to come here and give this very challenging topic. I know you've had a long day, so I just want to summarize my talk in one sentence, is that there is nothing you can do about late rejection. Once you have it, you're toast. And with that, I think, I say that with a joke, but that's a reality in 2017. But there's a lot we can do, and I think it's not just coming from the physician side. It takes a multidisciplinary kind of approach to manage our patients and prevent rejection, late rejection, which is the key. So I think before I jump into management, I think we have to talk about what is AMR, what is antibody-mediated rejection. I will give you a brief overview, AMR 101, just so that everybody's up to date about this topic. I'm going to talk slightly on the treatment of acute and chronic AMR, for which there is not too much evidence. And lastly, I'm going to focus on what we can do to overcome this very important entity in transplantation. We have to start from the very beginning and remember that the first kidney transplant was performed in identical twins. And that is even because back in the 1950s, people recognized that if you put an organ transplant between genetically non-identical recipients, one gets rejection and loses the graft. So back in the 1950s, you got these two guys that look very much the same. But how does one prove identity between these two? Fingerprint, yeah. So that's what they said, right? These guys were trying to sell newspapers. And basically they said, well, if the fingerprints are the same between the two twins, then it goes that they're genetically the same, and therefore transplant should be safe. But is that true? No, right? Because your fingerprints are determined by what happens to you after your birth. So in fact, back in the days, they had a hard time establishing identity between these two twins. But what they did was a very clever way, is that they did a skin graft between the donor and the recipient, and they ensured the skin graft was successful before they moved on to kidney transplantation. But the point of showing this is to highlight that even back in the days, they recognized that with not very good immunosuppression, you have to do transplant between genetically very similar individuals if you're going to have a successful transplant. And I'm going to come back to this point. So that's the team that did a first successful kidney transplant in the Brighams in 1954. This is the team that did it. Joe Murray, on your far right, was a plastic surgeon, and he was actually awarded the Nobel Prize in 1991. But if you're going to do kidney transplant between identical twins, you won't get very far. And naturally, what they did was that they moved beyond identical twins and did it between genetically disparate individuals. But the outcomes were very poor. If you look at patient survival over here, about 40%, and uniformly, the kidney survival was very poor in the long term. And that is because in that era, immunosuppression was not very good. So that really spurred on a lot of research about rejection. People recognize that that is the reason why patients lost their graft back in the 1950s, and very much holds true today, as I will show you with data. Over the years, we've seen a lot of immunosuppression. We started with steroids and Imuran. But with time, we've had ATG. We saw a big breakthrough with calcineurin inhibitors, cyclosporin, and tacrolimus. And more recently, we've had, sirolimus, belatacept. But what's unusual is that despite that, what we have seen is that our rejection, acute rejection, seems to have improved. On your far left, you will see that between 1995 to the year 2000, if you look at the incidence of acute rejection, it's gone from somewhere that's in the realm of 30 to 40%, all the way down to 10%. And that's very much what we see in the clinic today. The incidence of acute rejection in the first year in our clinic is about 8 to 10%. But what's curious is that if you look at graft loss, in the long term, we've seen improvement only between 0 to the first year, but in the long term, everything has remained the same. So despite better medications, we haven't really made a major difference in the long-term outcome of our graft. It wasn't until in the past few years that we began to realize why that's the case. This is a study from the Alberta group, and what they found was that when they analyzed the kidney biopsies from transplant patients that failed and look at their clinical course and immunosuppression medication and DSA antibodies, They found that more than half of patients, the reason for their graft loss was attributed to antibody-mediated rejection. And that's established in half of them. Another 10%, they were probable antibody-mediated rejection. Another 5% mixed rejection between T-cell rejection and antibody-mediated rejection. So if you add them up, about 60% of graft in the long term were lost due to antibody-mediated rejection, which is the reason that we dedicate so much attention to this topic. So how are antibodies produced if they lead to graft loss? Well, we know that if you have a foreign exposure to HLA antigens, one makes antibodies. That can be in the form of pregnancy, blood transfusion, not so much with infection, but that can happen. And most commonly in our world, it's transplantation. That you're exposed to foreign antigens, you elaborate this immune response, making antibodies that attack the graft, and in the long term, they cause graft loss. We didn't have very good assays to measure these antibodies until about 2009, and we have very sensitive assays now. They're called single antigen beads that allows us to measure what these antibodies are and also to quantitate the antibodies as well, so we can determine how strong they are or how weak they are. And this is the result that we see. And in Canada, we've taken the approach that anything with a scale MFI over 1,000, then you start to call these as real antibodies. And you see here very strong in red. These are very high titer antibodies versus the ones that are very weak, as in yellow here. So with the assay, we have begun to put together data to say, okay, what happens to these patients that have antibodies? This is a very nice study from the Manitoba group. What they found was that patients that have donor-specific antibodies, I will call it DSA, in the long term, at 10 years, you can see that their graft survival is only about 50%, versus ones that don't have antibodies, their graft survival is actually quite well maintained in the long term. And that's been validated across many different studies today. So what do we think is happening these days after transplantation is that one gets a transplant that's successful, but post-op there may be changes that occur to these patients, which I will discuss, that propagate this elaboration of donor-specific antibodies with time. Now, they may not cause injury right away. That process may take months to even years, but what happens is that gradually there's inflammation in the capillaries of the kidney. You may or may not see C4D, which I'll talk about, more inflammation, and then eventually that progresses and leads to scarring or interstitial fibrosis and tubular atrophy, or IFTA in the long term. And by the time in the clinic, we see someone's creatinine has risen, it's gone up. Usually by that time, there's established chronicity in the graft. And if you're treating these patients, it's very difficult because by that time the antibodies are produced, it's very hard to stop this humoral process from continuing to get worse. And by that time, patients, they have a limited lifespan in terms of their kidney allograft. So how does one diagnose antibody-mediated rejection? If you work in the clinic, it used to be that you need 3 criteria, one of which is histology. And there's different criteria. As a fellow, I would work hard to memorize these criteria. But if there's one takeaway point is that AMR is a problem of the microvasculature. And that is because the HLA antigens, they're expressed on the endothelium. That's where they're kind of upregulated. And antibodies, they bind. And progressively, you get damage to endothelium that progress, leading to fibrosis in the long term. And because it's antibody-driven, one has to finally have a serological evidence for antibodies. 95% of the time, they're caused by HLA antibodies, but that means 5% of the time, they're caused by others. And I'm going to talk about one case. We couldn't even find out what the antibodies are, but the phenotype is very, very distinct. Again, when I was training, one has to establish C4D, which is a byproduct that's left after antibodies bind to the endothelium, triggering the complement cascade, but that's also changed as well. And I'm going to talk more about molecular diagnostics in transplantation because, as you will see, I think that's going to be part of the future in terms of diagnosis. Why do I talk about these criteria? Is because if you're going to pull a trigger to treat someone for AMR, the therapy is expensive, it comes with toxicity, and you want to be sure with the diagnosis before we just start to give patients toxic medications that have a lot of side effects. Okay, so one may ask, you've got antibodies, you've got biopsy, why do we care about gene diagnostics, gene set diagnostics? I'm going to talk about this case, which I was brought in as a consultant, immunology consultant. It was a weird case. This patient had a second transplant, very highly sensitized, lots of antibodies, but she was very lucky. She found a donor who was completely matched with her across all the HLA loci. So theoretically, she shouldn't have any rejection at all. But what happened was that after transplantation, her creatinine got better and then got worse right away. And it was kind of weird because she was so well matched with the donor. They were completely HLA matched. In fact, she has so many kidney biopsies, all of them here, that only show suspected antibody-mediated rejection. We checked for HLA DSA, couldn't find any antibodies at all. But despite that, the clinician who treated her at the time really believed that this injury was caused by antibody-mediated rejection, so treated her with a lot of immunosuppression, with methylprednisolone, rituximab, plasmapheresis, Velcade, splenectomy, so pretty aggressive. And not surprisingly, she had a lot of infectious complications because the more immunosuppression one gives, the more likely they're going to end up with recurrent infections, and that's what happened to her. So I was brought on here, and then people were scratching their head, saying, "Well, that doesn't make any sense. Why would she have antibody-mediated rejection?" The first thing to know is that despite having no HLA antibodies, one can still have non-HLA antibodies, and that's the first thing that I did. We tested her for non-HLA antibodies, and they were all negative. So at this time, it was a bit bizarre, and luckily, next to us in Alberta, Dr. Halloran had designed this gene set, which can help us with diagnosis in these difficult cases. So what happens is that if you have two patients, you have one patient who has a transplant, doesn't have any rejection, they have a very unique genetic signature. Conversely, in another person who has a rejection, their genes that are being expressed are different. So by doing this type of gene set studies, one can actually come up with a signature that predicts rejection. And that's exactly what we did. That, when you plot out a volcano assay, one can discriminate and put them into a category of no rejection, T-cell rejection, or antibody-mediated rejection, or mixed rejection. And when we did it for our patient, she fell into this group that had a very high antibody-mediated rejection AMR score. So on that basis, we said, okay, you do have a confirmed diagnosis, and we pursue her antibodies. We actually found out that she has anti-endothelial cell antibodies. And to this date, she continues to get treatment, and her kidney function is stabilized. The whole point of talking about this is that this assay, up until recently, has been a research diagnostic, but soon it's going to be a commercial assay. And I would actually submit that in the future, anytime we have a tricky diagnosis or diagnosis is unclear, it's a very powerful tool before we decide to embark on a prolonged treatment course of immunosuppression for our patients. So last year, we kind of sat down and then we said, okay, how are we going to treat patients with antibody-mediated rejection? Because if you work in a clinic, you will find that different physicians have different concoctions that they like to give. Some more aggressive, some not so much. If you look across different organ groups between kidney and heart and liver and lungs, we also use different regimen as well. And that is because the evidence has not been very good for the treatment of AMR. So Tom is over here. We sat down and we said, it's really not for the benefit of the patient that every week a different physician comes on, gives a different concoction, and the next person comes on, may decide to go a separate way. We decided to review the evidence for the treatment of AMR and come up with a provincial protocol that we thought that was reasonable for everyone. And that's exactly what we did. So if you look at the KDIGO guidelines about what to do for patients with AMR, they simply suggest that you can do one or more of the following. And it mentions plasmapheresis, IVIG, rituximab, or even ATG, but it doesn't really tell you which ones to give or how to give them. There was an FDA workshop in 2011 that said the standard of care is either plasmapheresis with IVIG or high-dose IVIG. Again, different people have different feelings about these regimens. If you look at the evidence for the treatment of AMR, and this is a high-dose IVIG. First of all, look at this date. It's from about 2000, so it's quite a while ago. And look at the number of patients, 42 patients. So that's pretty low small sample set. And even with high-dose IVIG, 30% of patients have rejection, 7 lost their graft. So right away you see that the evidence is not super strong. It kind of works, but it doesn't work all that well. And then next, this is the Hopkins protocol. They use some plasmapheresis and low-dose IVIG. Look at the N number, 7 patients. Again, this is a very, very small study for which kind of people started to use this regimen afterwards. But suffice it to say, the evidence is not very strong as well. More recently, this is a group from Paris. They added the use of rituximab between 2 different groups. One got rituximab, the other one did not. And again, we're talking about 12 patients in each arm. They show some benefit with the rituximab group, but again, the sample size was very small. And also, these were not contemporaneous transplants. One group A was performed in the earlier era, the other one was a later one. So if you look at all these protocols, none of them were really well studied. But be that as it may, we kind of come to a consensus, and this is a protocol that we have. And we have multiple people review this, made sure that everybody was happy with it. And the protocol as it stands, what we do is we do plasmapheresis, 3 in a row, followed by low-dose IVIG. We do give 1 dose of rituximab, and then we continue plasmapheresis for a total of 8 sessions. And then we do repeat DSAs after we're done with the 8 courses of plasmapheresis. We may consider rebiopsy, and depends on the repeat CD20 cell count, we may or may not give the 2nd dose of rituximab. But the caveat is that this is for acute antibody-mediated rejection, for which there's more evidence for treatment. My talk today is about chronic antibody-mediated rejection, but if the evidence is so poor for acute, you can think about for chronic, we really have absolutely no evidence in what we're doing. I'm sorry to sound so negative, but that's the fact. Okay. So what is chronic or even late rejection? So very briefly, there's T-cell rejection and there's antibody-mediated rejection. These days, T-cell rejection is very well taken care of. A course of steroids or even ATG will pretty much wash away the T-cell rejection. AMR is the one that's more difficult to deal with, as I've shown you here. This is a study that's very interesting. So if you look at late rejection, most studies will not specify which type it is. Dr. Halloran's group did a very interesting study looking at the occurrence of which type of rejection over time. And what he found, this is quite striking, is that if you look at long-term, the print is kind of small, but what you can see here is that for T-cell rejection, it pretty much disappears 10 years after transplant. Even at 5 years onwards, it's not very often. Okay, so for whatever reason, T-cell rejection just gets extinguished over time. And if your patients have issue with rejection afterwards in the long term, it's mostly AMR, as you can see here, that despite the decreased prevalence of T-cell rejection over time, AMR kind of persists. Okay, so let's take home point number 1, meaning that if you have someone with late rejection, if you're just giving them steroids, it's probably not going to help you too much because AMR is more complicated, that giving a burst of steroids probably is not going to do too much good. The second point to note is that over time, C4D, negative AMR, becomes more common as well. In more of the acute phase, one tends to see C4D, but with time, with long-term chronic rejection, C4D negative AMR becomes very common and has been reported up to 60% of the time. So it used to be in the past that one needed C4D to make a diagnosis of AMR, but that's no longer the case. Okay, so again, this is the model that we have for AMR. I've gone through walk you through this slide here. But what's interesting is that for long-term chronic rejection, you can catch these patients along a very heterogeneous spectrum. You may have detected these patients early on when they're having inflammation and they have DSA, or you can be catching them very late when the creatinine has gone up. And depending on where you find a patient, it's very difficult because, as you can imagine, with more chronicity and scarring in the kidney, treatment probably doesn't help that much. Conversely, if you find them early on, then treatment may give you more benefit. And that's exactly the general principles that I have. Number one is that AMR is very difficult to treat, and one has to consider the side effects and the cost of treatment as well. So it's not because we don't have fancy drugs. This is a study from Johns Hopkins, and what they did was that they treated late AMR with conventional and novel therapies. Novel being bortezomib, which is a proteasome inhibitor. So what they found was that only 35% of patients had improved allograft function. 3 out of 8 had a complete response. 5 out of 8 had only partial response. And what they found was that what they saw as improvement initially at the end of therapy was not sustained, that they seem to have gotten better, and then if you follow them longer term, they got worse again. So very difficult to manage. About half of the patients, they have persistent injury on biopsy, even after treatment. So you spend all this time and money giving them expensive treatment, but it just couldn't extinguish the AMR course. So their conclusion was that by adding bortezomib to refractory AMR did not improve outcomes at all. So number one is that it's hard to treat. Second is that late AMR is more difficult to treat compared to early. This is a study from Steve Whittle's group in Cincinnati, and then they examined patients that got treated with early AMR defined as under 6 months versus late AMR over 6 months. And what they found was that there is the effect of diminishing return. Okay, so the ones that had early AMR, when they got treated, their kidney function GFR increased from 40 mils per minute to about 65. But you can see the improvement is actually much less when you're 6 months out. Most of the time when we see clinic patients, they are many years out. And it's not uncommon that we give them a lot of therapy and then we find out their creatinine has not changed at all. The third general principle is that we like to identify who is going to respond, because it's clear that some patients respond to treatment whereas others don't. And what we know is that patients that have a concurrent T-cell rejection, they don't seem to respond as well to the antibody-mediated rejection. And that could be because the T-cell component is not treated by our AMR protocol. They may need ATG. The other reason could be that when you have mixed rejection, T-cell and AMR, it reflects non-compliance, which is a poor marker in these patients that have rejection. When you look at who's going to respond versus not, there tends to be a bias in the patients that come in with creatinine that are already quite elevated, 300 to 600, they tend to be non-responders, versus the responders, they tend to have a lower creatinine. And I think that's very intuitive. If you find someone who has trouble early on, before they have scarring, you treat them, they're more likely to have benefit versus someone that's already late in the course. And by the time you have proteinuria in the patient, then they already have quite a bit of scarring, and not surprisingly, they tend to be non-responders. Okay, so after all this, what do we do for these patients? Who gets treated and who doesn't get treated? AMR is a continuous spectrum, you can start very early with only antibodies. They don't have any clinical dysfunction, or it can be very late. They actually have chronic injury, but they don't have any inflammation. So the easy thing is that when this happens, when they have no active inflammation, then we don't treat them because it's not going to help. On the other end, when they're very early, then it's difficult because many patients, although they have antibodies, they actually don't develop dysfunction, but some clearly do. So I think that warrants a bit of a discussion between the clinician as well as the laboratory to decide how we're going to monitor these patients to ensure that if they have any spike in their antibodies, for instance, or if you monitor them, the creatine's going up, or if you biopsy these patients over time, if there's any hint of problems, then you go ahead and treat right away. When we catch these patients somewhere in between, then it becomes a bit more difficult. So we haven't really hashed out the details of when and who we're going to treat. But suffice it to say, if your creatinine is kind of high at baseline, if you have very little inflammation, or you have a lot of chronicity, scarring, then we tend to just leave the patients. But it doesn't mean we kind of leave them to their, to fail, but we optimize their immunosuppression. We find out why do they have rejection? Are they non-compliant? Are they taking subtherapeutic doses of medication? And we optimize that for our recipients. Okay, so it's been pretty depressive so far. I tell you that AMR causes failure for most patients, that nothing that we do seems to help them. But how are we going to overcome AMR? And I propose there are several ways that we can do that. And I don't think our future is so bleak. The first way is that let's find out who makes antibodies, because clearly many patients, they do fine. But let's find out what are bad actors first. And these are the ones we need to pay attention to and monitor them more. This is a study, again, from the Manitoba group, from Peter Nickerson and Chris Wee. What they found was that, surprise, surprise, when you have non-adherence, they have a very high odds ratio for forming antibodies. And I would submit that this is something that's not well addressed, and we don't pay much attention to this as we ought to. That I think even in the pre-transplant phase, we kind of get a sense which patients are non-compliant, which are more compliant. And that information needs to get relayed to the post-transplant team and needs to be followed up and flagged for these patients so that every time they come in, we talk to them about compliance and we monitor their TAC levels. We find a way to ensure that they're taking their meds. The second risk factor is donor-recipient mismatch for their HLA antigens, which I'll talk more. And then the last risk factor is that if someone has a rejection, it follows that they're more likely to get antibodies afterwards. And therefore, we may want to pay more attention to these patients that have early rejection. Although they're well treated, they may have consequence in the long term. So these are the kind of the risk factors proposed for non-adherence. And I'm not going to go through these, but I think we should pay more attention to that in the clinic. But the second thing is HLA matching. If we go back to the very beginning, we started with transplants between identical recipients, HLA identical recipients. And why don't we do it anymore? Why don't we match for recipient and donor HLA anymore? Because they're going to have less rejection. Well, the first reason is that we have better immunosuppression. So if you look at the effect of mismatch and graft failure over time, back in 1995, when immunosuppression wasn't very good, if one had more mismatch, there was a higher risk for graft loss. But with time, with better immunosuppression, you can see that it seems like mismatch is not a big deal anymore. And so people are reluctant, people are happy to say, you know what, it doesn't matter, we got better immunosuppression and therefore it's okay. Which we're paying for right now because it may be okay in the short term, but in the long term, not so much. The second is the equity of the HLA distribution. If you look at just one antigen, A2, which is the most common antigen in the population, 50% of the time, if you carry an A2, you want to look for a donor who's the same as you, then you don't have to wait for very long. Compare that to someone who has a rare HLA antigen like A80, where the frequency in the population is under 1%. If I'm going to try to give you a matched organ, then you're going to wait for a long time. So there's inequity if you're going to allocate organs that way. So for that reason, we've shied away from doing that. But the real question is there a way that we can perform matching that's more biological and not just based on HLA antigens? So I know I'm excited to talk about this, so I walk you through this slide here. So you've got a recipient who's got an antigen B7 and 4 different donors, right? So each one of them is a mismatch with the recipient. So they're one HLA mismatch. But the immune system is not so simple because the immune system actually perceives this donor as very little mismatch, as indicated in yellow, versus someone who has a lot of amino acid differences between the two. Okay, so what that tells us is that actually the way we used to do matching wasn't very physiologic, wasn't very biological, because donor recipients, the recipient immune response looks at the donor in terms of amino acids in a very defined area, the antigen recognition site. And that may be a more biological way of assessing what is the burden of mismatch between the donor recipient. And the reason I say that is because this is another very nice study from the Manitoba group. What they did was very interesting. They took patients that had 1 or 2 mismatches by traditional method, and then they look at their new way of looking at things called the epitope mismatch, and they found that actually these patients, although they have 1 mismatch or 2 mismatches, they can be further re-stratified into very high burden, 10 to 50 epitope mismatches, or very low. And with that, these patients actually did totally fine. So the whole point of talking about this is that there's a lot of momentum with this type of research, is looking at how do we optimize donor-recipient immunogenicity? How do we better match donor recipients without compromising their access to transplantation? And there's lots of studies ongoing right now to look at this. And the reason that's important is that the bottom line with transplantation is you're either taking too much immunosuppression or you're taking too little immunosuppression. If you take too much, you get infections. If you take too little, you get rejection. And most of the time we get it right, but oftentimes we don't get it right. And patients, they go between different states. They're either too much or too little. But if you can actually optimize matching between donor and recipient, you can actually get away with quite a bit. They don't need as much immunosuppression. They don't get as many side effects. And I think that is the future, that is the way to go in the future. So I've been very much interested in this slide when I came back to Vancouver, because if you look at who gets antibody-mediated rejection, half of the patients are not adherent, so you can blame it on the patients. Or the other half, they're actually adherent, but why do they still get rejection? And this, I think you have to blame on the physician. I had this hypothesis that perhaps when patients are told by their physicians to reduce their immunosuppression, that they may not get rejection right away, but over the long term, they start to make antibodies, and then they start to cause problems, and then they have dysfunction leading to failure in the long term. And why do physicians tell patients to take less immunosuppression? Well, there are many reasons. If you work in the clinic, again, our medications have a lot of side effects, and I was interested particularly in mycophenolate. If you've taken mycophenolate or seen patients take mycophenolate, you know that it's actually very hard to take. Many patients have GI side effects, nausea, vomiting, severe diarrhea, and they try their best, they just cannot take it. Many of them have low white blood cell count, and if you're a clinic nurse, that's what we struggle half of the time. Their white blood cell count is low, we have to reduce it, and then it gets better, we increase the dose, and then it goes down again, and then it's this back and forth. They may have BK virus infection, which means over immunosuppression. We reduce their immunosuppression, but we don't know if that's okay or not. And in some patients, they have malignancy in the long term. Okay, so for a variety of reasons, we tell patients to take less, but we actually don't know if that's okay or not. So I wanted to study how many patients have had their mycophenolate reduced in the first year post-transplant. And I was pretty surprised. So first of all, this is our BC data. We analyzed 360 patients at their mycophenolate dose in the first year. And what we found was that this is how many patients have had immunosuppression reduction. Everybody started off taking mycophenolate. And you can see that by 180 days post-transplant, so 6 months, about half of them have had their immunosuppression reduced for all the reasons I just discussed. So it's very common. We do it all the time. And I wanted to know what happens to these patients in the long term. Oh, so first of all, before I go there, how much do we reduce? Is it just a little bit, or we do it quite a bit? And what you see here is that we actually do it quite a bit. Okay, these tablets, they come in 250 milligrams, and the full dose is 1,000 twice a day. So only 40% of patients had the full dose within the first year. 20%, they were reduced down to half the dose. And another 20% at some point had their mycophenolate completely held. Okay, and I'm sure they were done for the appropriate reasons, but I wanted to know what happens to these patients in the long term. And when we stratified these patients, we found that you can divide them into 0 to 40%, so below the 50% dosage, or 50% or higher. And indeed, these patients that were taking less than 50% of the time, they had worse graft outcomes in the long term. Now, this study is not completed yet. I have to adjust for a bunch of recipient and donor baseline risk factors between the two groups. But clearly, there's a signal that if one is maintained on lower immunosuppression, that there may be problems in the long term. And it reminds me that when I see patients who are taking less immunosuppression in the clinic, I ask them, why do you take less? And if whatever problem they had before, diarrhea or leukopenia has resolved, I try to bring it back up so that, and oftentimes they tolerate the increase just fine. Okay, so I think I kind of went through the talk pretty fast. I know it's a big talk, and it's kind of getting late in the day, but the summary is that AMR is the main problem for late kidney failure. The chronic and late AMR are difficult to treat, so prevention is really the key for these patients. And how do we do that is by early identification of non-adherent patients. We find out who they are pre-transplant, monitor them post-transplant. Patients, donor recipient matching by epitopes is something we're going to work very actively on. In the lab, we're trying to generate reports that can give us an idea how mismatched the donor recipients are, and that's going to take a bit of time to be implemented. But we're hoping to do that sometime this year. And again, optimizing immunosuppression for now is kind of all we got, because by the time injury has happened, whatever big gun therapies we pile on don't do very much. Okay, so this is just a graphic depiction here that in a pre-transplant, we can find out from clinical risk factors who are the bad actors. Induction may play a role, and then the donor recipient matching. And then post-transplant, we can risk stratify patients by how well they do. Have they had neutropenia? Have they had BK virus? Have they had immunosuppression reduced? And we're in the process of testing a few biomarkers that can tell us how these patients' immune systems are without doing a kidney biopsy, because that's the major limitation, is that we reduce their immunosuppression, something may happen. The only way to find out is to do a kidney biopsy, but it's not realistic and practical for patients over time. But if we can have a non-invasive biomarker that we can follow patients' immune response over time, that'll be very powerful. So we're kind of looking at that as well. Okay, so I think I'll stop there.
Thanks very much, James. Any questions from the satellite sites?
Sure, I'll go. Hi, James. So my question is along the lines of what you were just talking about. We do have many patients who are on lower dose mycophenolate for legitimate reasons, and I just wonder, what are your thoughts on the steroid-sparing regimen idea in that case? If they're on, say, 1.5 immunosuppressants, should they be on steroids at that time?
I think that's an excellent question. I'm looking at the data between the steroid-free and the ones that are maintained on steroids to see if there's a difference. I don't have the data to support that, so but I think that's something that I can probably give you an answer in the next 6 months or so. What I would do right now is to find out why they're on less immunosuppression and see if we can try to push it back up. Again, that's why I wanted to find a threshold to see if there's a point after which they're at a higher risk. And what I found was that if you're reduced to about 75%, that's probably okay. But when it's the below 50% that I worry. The other thing that I see all the time is that patients, they have a lot of diarrhea. Another common reason why they cannot take full dose mycophenolate. And we try to shove mycophenolate into these patients, and they just say that they cannot take it. And they're on 250 BID, a quarter of the dose. If the patients have such poor tolerability, I would just take them off mycophenolate and give them Imuran. And I believe that taking such a low dose is probably not a good idea for these patients. They're better off taking a full dose over another agent, although being an older agent has worked well for many patients. Sorry, it's a difficult question to answer, so we just need more data to look at a steroid-free versus non-steroid-free.
Any questions from our audience here?
Sorry, I have one question. It's Jocelyn again in Kamloops. Do you have some guidelines around when we should order DSAs? Like, is it only if you get a biopsy back that has signs of something, or like, when does it come to your mind that it would be helpful to order the DSA? Because traditionally out here, until Catherine came, we would never order it. It was just, we weren't, in our minds, weren't allowed. So when would you do it?
Right. So ordering DSAs, ideally, I would like to screen patients, but it's quite costly to do so. It's about $500 per test. So if we broadly implement it across the board for our patients, then our lab will go bankrupt. So we don't want to do that. So that's why risk stratifying patients is important. So the ones I would do it are the ones that have had a T-cell rejection or vascular rejection. You've treated these patients, and they're the ones that have a higher signal for DSA formation afterwards. And these are the ones I would perform DSA, depends on when they have it, about 6 months afterwards, to see if they have formed any DSAs. When you have a biopsy that shows any evidence of antibody-mediated rejection, then those are the ones I would order DSA for sure, because you're talking about treatment. And as I said, you want to establish the diagnosis that relies on having to find the antibodies. So another point is that even if they're C4D negative, but the biopsy says suspicious, or it says chronic active or acute AMR, these are the ones we definitely need DSA to even begin treatment. So these are the two I would do routine DSA for now. Now, I'm in the process of actually setting up a biobank where we want to collect specimens from patients prospectively. We don't test them right away, but at least it's there. We can go back and test it if we want to. But for right now, our program is very much indication based, that if there's dysfunction, we would get it. If you rule out the other causes for clinical dysfunction, you suspect rejection, then I would get it. And definitely if it's positive, then call Vancouver, then, because then we're talking about treatment, and we can discuss on the phone.
I have one more question, if we could.
Yep.
Are you still doing ABO mismatch transplants?
Yeah, if the opportunity arises, we have done. We did one last year.
Yeah, we don't do it very many as Owen here. We did one last year. It's not the first thing that we jump to because of the pair exchange, but we do look at it, and we've done successful ABO incompatible transplants. And if you look at most of the studies that look at ABOI, they actually have very similar outcomes to ABO compatible transplants. We will not do ABO incompatible transplants if there's a DSA as well, but purely ABO incompatible transplants, particularly in someone whose donor is A2, we will do that because the A2, the antigen is only expressed on the cells about 25% of A1. So they have a much lower risk for rejection. And we like doing that. But depends on the ethnicity of the donor. That's only in about 10 to 20% of the blood group A donors.
Anyone here like to ask a question or comment? I think that's all the questions. Okay. Thanks very much, James. So this is the end of our education day. Thank you all so much for staying for the duration. It was very interesting topics that we covered today, and I hope that you all got a lot out of it. The talks have been recorded, and as mentioned earlier, they are available on BCT YouTube. And a special thanks today to Claire and to Jamie for helping to organise this, and Dom for your technical expertise, and to all our speakers for taking time out of their day to come here. And for all of you who travelled today, thank you. And to our outside sites, thank you for joining in. And hope that we can continue this again next year from outside sites like this. Thank you very much.